In recent years, we have seen an exciting proliferation of options for performing minimally invasive glaucoma surgery, MIGS. MIGS refers to a group of surgical procedures that lower intraocular pressure, mainly via ab interno approaches, which are less invasive and involve fewer risks than traditional filtering surgeries, such as trabeculectomy or tube shunts. Most MIGS procedures involve the use of micro-stent devices which improve aqueous outflow through a physiologic pathway. MIGS procedures fall on the spectrum of therapeutic options for glaucoma, between non-invasive medical and laser therapy on the one end, and more significantly IOP lowering, but also more aggressive filtering surgeries on the other. MIGS can be highly successful in patients with mild to moderate glaucoma, and because they spare the conjunctiva, these procedures preserve the tissue for more aggressive filtering surgery as a future treatment option should it become necessary. As is demonstrated by the case I present today, even as MIGS devices and procedures continue to evolve, outcomes still depend on careful surgical technique and postoperative management. This case involves a 64-year-old female patient who presented to our practice complaining of decreased vision, especially at night. Examination revealed significant cataract, and the patient also had glaucoma, which was controlled using 2 topical glaucoma medications. As the patient was motivated to reduce her reliance on glaucoma drops, we discussed the implantation of the iStent trabecular micro-bypass stent in conjunction with her cataract surgery. The first-generation iStent is a 1 millimeter long, 0.3 millimeter tall, L-shaped titanium implant designed to allow aqueous to flow from the anterior chamber directly to Schlemm's canal, bypassing the trabecular meshwork. The iStent is FDA approved for the use in conjunction with cataract surgery in patients with mild to moderate open-angle glaucoma. The iStent is typically not implanted as a standalone procedure, but is done at the conclusion of a cataract surgery, inserted into Schlemm's canal via the trabecular meshwork using a preloaded inserter. This patient made an ideal candidate for the combined procedure because she had symptomatic cataract and early open-angle glaucoma. She was already on more than 1 glaucoma drop and wished to decrease the burden of drops for managing her glaucoma. Here we have completed the cataract procedure and are ready to insert the iStent. I have added more viscoelastic to deepen the chamber, and I enter the eye through the same clear corneal incision used in the primary procedure. Using a gonio lens, we are able to visualize the angle and can see Schwabe's line, pigmented trabecular meshwork, scleral spur, and the ciliary body. I then approach the upper part of the trabecular meshwork at an angle of 15 degrees, engage the meshwork tissue, and enter into Schlemm's canal. You can see the iStent moving forward into the canal. I release the iStent, and then I just use the tip of the inserter to gently tap the snorkel end of the implant and make sure it is properly and securely placed. We can see that the implant fits nicely in the canal. Now I remove the viscoelastic in the anterior chamber. There is a little reflux of blood in the area where the iStent was implanted, as seen when removing the viscoelastic. This is a good sign, as it shows me that the iStent is well positioned and already communicating with the venous drainage system. The surgery went well, and the iStent remained in good position. Following the surgery, the patient was placed on topical ophthalmic corticosteroid drops and a topical non-steroidal anti-inflammatory drug to control inflammation and ocular pain. On postoperative day 1, the patient's IOP was in the mid-teens, but at her visit 1 week later, the IOP was 35 millimeters of mercury in the operated eye and 18 millimeters of mercury in the fellow eye. Since the patient had no optic nerve head changes or visual field loss, to address the elevated IOP, I instructed her to discontinue the corticosteroid eye drop she had been using and replace it with Lotamax, loteprednol etabonate ophthalmic gel, 0.5%. I asked her to return a week later, and when she did, her IOP had come down to 20 millimeters of mercury. A month later, the patient's IOP was stable at 16 millimeters of mercury in that eye. Lotamax gel is a gel formulation of loteprednol etabonate, which is engineered to facilitate adequate residence time on the ocular surface and, in contrast to its suspension formulation, does not require shaking to ensure dose-to-dose uniformity of drug delivered. Lotamax gel is indicated for the treatment of postoperative inflammation and pain following ocular surgery. And importantly, for this patient's case, it offers a proven safety profile and a low propensity to cause significantly elevated IOP. For this patient, Lotamax gel offered continued inflammation control without the worrisome IOP spike. When we removed the cataract and implanted an iStent in this patient's fellow eye, We began with Lotemax gel straight away, and the patient experienced an uneventful post-operative course and a rapid visual recovery. Her second eye did not exhibit any significant IOP spike, and it was 18 millimeters of mercury at post-operative week 1. After a month, the IOP in the eye had settled to 16 millimeters of mercury.
Indication: Lotemax gel is a corticosteroid indicated for the treatment of postoperative inflammation and pain following ocular surgery. Important risk information about Lotemax gel. Lotemax gel is contraindicated in most viral diseases of the cornea and conjunctiva, including epithelial herpes simplex keratitis, dendritic keratitis, vaccinia, and varicella, and also in mycobacterial infection of the eye and fungal diseases of ocular structures. Intraocular pressure, IOP, increase. Prolonged use of corticosteroids may result in glaucoma, with damage to the optic nerve, defects in visual acuity, and fields of vision. If this product is used for 10 days or longer, IOP should be monitored. Cataracts. Use of corticosteroids may result in posterior subcapsular cataract formation. Delayed healing. Use of steroids after cataract surgery may delay healing and increase the incidence of bleb formation and occurrence of perforations in those with diseases causing corneal and scleral thinning. The initial prescription and renewal of the medication order should be made by a physician only after examination of the patient with the aid of magnification. Bacterial infections. Prolonged use of corticosteroids may suppress the host response and thus increase the hazard of secondary ocular infection. In acute purulent conditions, steroids may mask infection or enhance existing infections. Viral infections. Use of corticosteroid medication in the treatment of patients with a history of herpes simplex requires great caution. Use of ocular steroids may prolong the course and exacerbate the severity of many viral infections of the eye, including herpes simplex. Fungal infections. Fungal infections of the cornea are particularly prone to develop coincidentally with long-term local steroid application. Fungus invasion may be considered in any persistent corneal ulceration where a steroid has been used or is used. Contact lens wear. Patients should not wear contact lenses when using Lotemax gel. The most common ocular adverse drug reactions were anterior chamber inflammation, 5%, eye pain, 2%, and foreign body sensation, 2%.